You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology and pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's jump right in. Today's Q Switch episode dives into how one surgeon transformed uncertainty into opportunity and built a thriving premium care model inside one of the Southeast's most respected ophthalmic practices. My guest is Dr. Jason Brody, a board-certified ophthalmologist specializing in cataract, anterior segment, and refractive surgery at Woolfson Eye Institute, a leading private practice now in its 24th year based in Atlanta that's become synonymous with surgical excellence and innovation. When the world was slowed down in 2020, Dr. Brody decided to speed up change. He saw an opportunity to create what he calls a practice within a practice, a premium, patient-focused segment dedicated to advanced technology lenses, laser-assisted cataract surgery, and refractive solutions for patients seeking more than just the standard of care. In our conversation, we'll unpack how he built this model from the ground up, the challenges, the technology investments, the team dynamics, and how he's leveraged both social media and AI to keep it thriving. Dr. Brody, welcome to the Q Switch.
Thanks, Spence. Thank you for having me. Good to be here.
Great. Well, thanks for making the time and coming on. Dr. Brody, you've been with Woolfson Eye Institute for over a decade, and in 2020, you decided to build what you describe as a practice within a practice. Can you take us back into that moment when what was happening during the early days when the pandemic that inspired this new direction?
Yeah, so I don't know that I would necessarily say it was building a practice, but I would say that I made some adjustments and I kind of took a look at what was going on as we were shut down. You know, we weren't able to perform elective surgeries at all, pretty much March, April, and part of May 2020. And so I realized that, you know, patients were going to be relying on online information, not so much telemedicine, although some of our providers kind of looked into it, but it's very difficult to do an eye exam. Just the technology is just not there to be able to really do a thorough eye exam, through telehealth. But I think patients, as we came out of the pandemic, started to rely more and more on online reviews, looking at websites, looking at physician CVs, physician resumes, reading bios, getting feedback from other patients, word of mouth kind of thing, and also doing a little bit more research on the technologies that might work for them or that they might be interested in. So I kind of started really focusing more on just making a little bit stronger online profile, online presence, just paying more attention to review websites and just making sure that, kind of my practice and how I wanted to practice was presented in the best light online.
So you're saying that patient behavior changed due to obviously the pandemic. Everyone's shut in. They're not going to work. They're not doing things on a daily. They're hardly going to the market. They're oftentimes just looking at a screen. And what else to do besides, if you're, I guess done death scrolling, you try and look at things that are going to help you. And obviously, if you're having some eye issues, you're going to do the things that you said. Look at the practice, dive deeper into the backgrounds, the social proof, the Google reviews, and all that. So the patient behavior changed, which almost dictated you as a provider to change as well.
Yeah, I think prior to COVID, in general, cataract surgery patients, if you think of the demographic, it's, most people think of Medicare age patients, so it's
Right.
age 65 and older. And if you go back in time 10 years ago, maybe less so 5 years ago, that demographic was not the most savvy online, compared to younger folks under age 50 and obviously younger than that. But I think with the pandemic, even older folks really kind of had to become more online savvy and relied more on reviews or websites because they really just they weren't going to their doctor physically, so they couldn't ask the doctor, hey, who do you recommend for this or that? And they weren't really going out and, maybe they weren't going to church or going shopping. And so they weren't out interacting with different people and saying, hey, my vision is a concern, who did you use for your cataract surgery, or can you recommend an eye doctor? So I think that really kind of caused a much more focus on on online reviews, online presence, and things of that nature.
Hmm. So many physicians were in like survival mode in 2020, but you saw an opportunity. What did you identify as the biggest gap or need in the market that led you towards creating a more specialized premium pay model?
Well, I think having the technology available, which we're ophthalmology is a very tech forward and tech savvy, specialty of medicine. We've
Hmm.
been into lasers, we're into all different kinds of optics and different kinds of, uh, even some very high tech surgical implants, tiny little implants, whether it's MIGS implants and all the different lens, IOLs. So that technology was there. But I think and my practice has always been sort of a little bit of a premium practice, but I think just being able to leverage all of the new technology that was coming down the pike. And I think research and development was still continuing even during COVID. Maybe those things weren't coming out clinically yet, but there was definitely work being done during these 3-4 years of sort of COVID and post COVID,
Hmm.
where there was some new technology coming out. And I think we just decided that, in my practice, we wanted to really leverage that technology, utilize as much technology as we could to educate patients, not just the actual surgical techniques and technology, but actually using iPads, using text messaging to send videos to patients, educating optometrists on the different technologies. So pre-educating our patients before they come into the clinic so that you're not overwhelming them with tremendous amounts of information and then giving them a bunch of choices where they're having to make a decision. So the more that I found, the more that our patients were given an opportunity to learn about the technology available prior to their visit, it made them less stressed at the visit, gave them more time to think about it, and also stimulated some questions that they might have. And in fact, I'm even seeing nowadays that a lot of patients will come in asking for a particular technology or even a particular lens, which
Really?
I think is something that's developed more in the last 5 years or so.
Huh. Okay. All right. Yeah. Because I know I've been in the game, of ophthalmology for like 14 years now. And when I first started, I think there were just a handful of lens manufacturers that were notable: Alcon, J&J, B&L, and they all had their own little niche and special lenses. But right around, I guess, right before COVID, 2019, there was an explosion, and new companies and even those same names I just mentioned came out with even more, IOLs in all the different spaces from toric to, EDOF and ATI, all this alphabet soup of different types of
Hmm.
lenses. It can get
Right.
confusing. And that happened right around the
Yes.
same time you started to make this shift.
Right.
Yeah.
Yeah. I mean, it can be overwhelming, and there's even more technology in the pipeline, and now within. I mean, originally, obviously, there was one EDOF lens, which was basically the Symphony. Then Alcon came out with the Vivity. Then J&J came out with sort of a modified monofocal plus, which sort of is EDOF, and then you've got light adjustable lens, and then light adjustable LAL plus now, and now there are multiple trifocals, and then there's even other trifocals which are coming down the pipeline very soon from
Hmm.
other companies, European companies that have not quite gotten their FDA approvals yet, but they're going to be coming very soon.
Hmm.
So it can be overwhelming, but I think that in my practice we try, and I use technology that I'm comfortable with, that I have a track record with, that works well, that has good results. And we try and limit the choices. I think patients do well with 3 or maybe 4 at the most. I think if you give them more choices than that, their heads explode, and they just become overwhelmed. So we try and hone in on 3 or 4 at most choices of technology, or let's say IOL or vision options. I like to sort of use vision options more than IOL options. So for
Okay.
example, if I'm counseling a patient and let's say they have no other ocular conditions and everything's on the table, it's generally going to be sort of option 1, which is going to be a standard treatment. You'll get the standard lens, no laser, and you'll get glasses afterwards for whatever your additional needs, whether it's distance or near. The
Hmm.
sort of middle option is going to be correcting any astigmatism and sort of maximizing their distance vision generally. And then they'll need reading glasses or glasses for some kind of close vision, whether it's computer or reading. And then the third option is essentially, I don't want to wear any glasses at all. Now, sometimes you can achieve that with different pathways. But in essence, if you boil it down, basically you're going to wear glasses all the time. You're going to wear reading glasses, or you're not going to wear glasses at all. I found that to be fairly straightforward. And I think patients do very well understanding those three sort of pathways. And then within that, there's sometimes more than one. And occasionally I'll give them a few choices within each avenue there, within each pathway. And I think that's served pretty well to help simplify things and give them permission to choose, because option 2 and option 3 generally is going to be a premium option. Option 2 is usually going to involve either femto laser and or a toric lens, and option 3 is you're going to usually either going to involve a multifocal or an LAL, or less likely an EDOF. So it's more of a pathway, and then from there I tell them, let me figure out the technology, and you don't have to worry about that as much.
So when you decided to pursue this new path, what were the first steps you took to bring this concept to life, and whether it meant, new technology, infrastructure, or team alignment?
Basically, I think it's a multi-level or multifactorial approach. Basically, there's maybe 6 or 7 different tiers that I use to get the patient from even before they're even walking in the door, to be honest with you. But when they call to make an appointment, to the time that they're actually going through with their surgery. So the first step would be either having that referral source, whether that's an optometrist or a word of mouth, where somebody is basically saying, hey, I went to Dr. Brody and I had a very good experience. His staff was really good. Everything flowed very smoothly. It was done professionally. Everything was competent. I had good results. I was satisfied with the overall process. So that's the first step. Once they then are calling and making an appointment, we are usually texting them information in the form of either videos on cataract surgery or on certain technologies, or videos that I might have done, introducing myself. So they're getting some, as I said, some educational information prior to the visit, which is helping kind of stimulate some thought. Then they're coming in, and my nurse or technicians are actually extremely well trained and very, very good. They have the people skills and the technical skills to make the patients feel comfortable. They're explaining what they're doing, and they're answering some questions along the way. So the patients are, again, getting additional information that's moving them toward that end game. Then they'll watch a video in the office, usually on an iPad, which will describe cataract surgery and some of the options, whether it's traditional versus laser or some of the different IOL options, while they're dilating. So they're getting additional educational information and we're utilizing that time, that downtime when they're being dilated. Instead of them just playing on their phone, they're actually thinking about and learning about maybe some IOL options, or the fact that we use a laser, whatever that they might not have known about. Then I'm in the room with them, doing the physical exam and evaluating not just whether they are a candidate for one technology versus another, but also just, to asking them questions about their personal life, about what they do, about what their needs, what their wants. Do they wear contacts or not? Are they working still or not? Are they active? Do they, play sports? Do they have certain hobbies? So I'm kind of collating all that information. And then after the exam's done, I've had a chance to assess them, take in all of the information. Then I'm saying, okay, here's what I see right now. You can go with option 1, 2, 3, 4, whatever it is. And here's what your vision would be like after surgery. Does this appeal to you? And then the patients will usually say, I really like option 1 or option 2, or they might say, I'd like to know more about this, a third option. And then they're going, after they're done asking me questions and they've got everything they need from me, they'll spend more time with my surgical coordinator, one of my 2 surgical coordinators, who are also very knowledgeable, because not only do they see the patients before, during, and after surgery, but they really keep in close touch with them. They get a lot of feedback. And so they can help patients feel more comfortable. They explain the financial part. They can answer questions about, well, what have you seen other patients that have had this third option, this trifocal? What's been your experience? And they'll say, 99% of these folks are really happy, whatever it is. And so after all that, and now they've had, 4 or 5 layers of information sort of repeated over and over again, and they feel very comfortable with it. Then at that point, they'll make a decision ultimately as far as what they want to do. But it's that repetitive information, that, sort of reinforcing information, and just feeling very comfortable with every step of the process. That's really, I think it needs all of those things to get them across the finish line.
So you were what I like about about your process and the layers that you put together is that you start this, for lack of a better term, like bread trail when they're at home on their couch,
Mm-hmm.
and you are holding their hand all the way through that patient journey. You are right there with them. Either you or one of your very well trained, well informed staffs that again engage with that patient, and so they're not kind of left on their own until the end when they have to make that decision. And I think from the patient perspective, I think that's very empowering, and it gives them a lot of confidence. So when they make that decision, it's quick, it's decisive, and they know what they want because they've had all this information, not once, twice, but 3 times, that's been kind of really spoon fed to them, and they're very comfortable with it. And I think that is masterful.
Yeah, I think that approach has really helped. I mean, having a very good team behind me
Mhm.
is extremely helpful because, again, they're not just, the technicians are not just checking pressures and visions. They're knowledgeable, and so they are able to answer questions, and they are able to get information from the patients, which ultimately help me and the patient make a decision. And they're including that in the chart, so they're very savvy on that, and they have very good people skills. So I only surround myself with people on my team who have, integrity, who are reliable, who have the people skills, who are smart. And so having a great team around you allows the goal to be met, because you really can't get the patient across the finish line if somebody's not doing it right. If the patient's not comfortable with the technician, then I'm going to hear about it. If the patient's not comfortable with the surgical coordinator, even after I speak with them and hand them off, I'm going to hear about it. Or Mrs. Jones didn't book surgery, something was mishandled, or they were misquoted in the price, or something got, the phone call wasn't answered right away. It was 2
Mhm.
days later. Again, I sort of use the term like customer service. It really
Sure.
kind of, you have to have smart people, but you also have to have the right customer service, and things have to flow. It has to be done professionally. It has to be done sort of, there's got to be a sequence, and it's got to be well organized. And so everybody has to work together as a team. So the teamwork, the repetitive nature of it, and then be just really, I get a lot of good feedback in terms of patients feeling like things were explained properly, they had plenty of time to make a decision, and that things were handled throughout the process smoothly. And
Mhm.
that's been very good feedback.
So you talk about members of your team, they all have their role and they know how to execute in their role, which I think again you mentioned continuity of care from the technician to the nurse to the front desk staff to you. There's continuity and there's a flow. So are these folks dedicated like just to you? Because oftentimes you have a large practice like a Wolfson, and you got to be the technician will also have to do a scribe, and everyone has several jobs. What is the team comprised of, and are they dedicated just to your service?
That's a really good question. So the way I do it personally, and this is the way I have done it really almost since I started,
Hmm.
which was back in 2012, but fairly early on, say 2010, 2012, I recognized that I work better when I have a core group of people that I train, that sort of do things my way, or the way
Sure.
I'd like them to be done. Let me put it that way.
Hmm.
And that I know that they're going to follow certain protocols, and that we're all on the same page. I find that if there's a lot of interchanging between team members, what happens is, number one, a lot of them don't know the little specifics that I might want. I might want this particular topography done, or I might want, if the test results don't come out the way I like, maybe there's a suspicion of dry eye. A tech that's just kind of doing 10 different things for 10 different doctors might not know. Whereas my techs know, like if they get, let's say, an IOL master or something, and they're getting, very inconsistent results, they're going, oh, I wonder this patient has dry eye. Let me go ahead and get this patient let me reshoot these. Let me get the patient to blink more. Let me get the lid open. They just know the little nuances.
Hmm.
And so on a technical basis, I just find it's better to have people that really know exactly what I want and what I'm doing. And then on the personal level, I just, if I feel really good when I meet a technician or somebody that I just really like their personality, they're warm, they're caring, and not just caring meaning they're compassionate, but that they care. They're not just punching the clock and being shifted around from team to team.
Mm-hmm.
They actually are invested in my patients that are seeing me in within my practice, my little silo, if you will. And then surgical coordinators, I mean, they are really responsible for putting the charts together, making sure I've got the right data, making sure we're getting everything done correctly, and then communicating with the patients and making sure that the follow-up is being done properly and that the patients are happy. And if there's a problem, they're just right on it, dealing with it and nipping little issues in the bud and dealing with those kind of things. So I find that my core team, and I have 3 technicians and 2 surgical coordinators that are basically with me, 24/7, if you will, when we're
Mm-hmm.
working. Obviously they don't work when we're off, and I don't bother them after hours or on weekends, but, we work normal hours. Let me put it that
Yeah.
way. But when we're together, they're on my team and my team alone. And then we do occasionally have floating help on days when we're busy.
Mm-hmm.
And even there, I like to try and have certain floating techs that I work with regularly, and I'll make sure that they are kind of trained so they know what I want. So I find that's a big key to my success, is having the right support staff around me. And
Mm-hmm.
it's not just a matter of just give me whatever techs are here, or just give me anybody that can, read this patient, tell them how much their surgery is going to cost. It is way more involved in that, and you have to have people that care about the patients, and you have to have people that want to really have the patient experience be top notch from start to finish. And I think that's a big key to my success.
Well, good, good. So you've always been an early adopter to technology, like many ophthalmologists. What equipment upgrades or innovations became essential to supporting this premium patient experience, and how did you evaluate what was truly worth investing in?
Yeah, so I think that's a really good question, and there's no right answer. I think each practice, each doctor, each surgeon, it has to kind of decide what works best for him or her. For me, I prefer to get 2 biometry readings on each patient. So on every patient I do cataract surgery on, I'm using either a lens star and an Argos, or a lens, or either lens star, Argos, or IOL master. Let's put it that way. Two of those. Okay. Sometimes I'll get all 3. If I'm doing a multifocal on somebody that's a bit older and maybe has some dry eye and maybe just, has some issues, I might get all 3, or contact lens wear, until I get what I want. And then I'm always getting a topography, and that's usually either a Tracy topography or occasionally a Penacam. But again, there are many different biometers and topographers, but I think you got to have multiple sets of tests on every patient to really get the best results. Obviously, we use a femtosecond laser, have that available, and obviously, individual surgeons. I mean, I use Alcon phaco equipment. Obviously, other, that a lot of these things can be interchanged, and
Sure.
there's nobody's gonna, I'm not gonna sit here and say that you have to use this or you have to use that. Um, that works for me, and I think if I have great technicians using great equipment, then we're going to get very good measurements, and then we're going to have very good results. If your technicians are not reliable, or you're not using updated equipment or are really savvy on that, then you might need to look like it's something like an aura, because you're going to be basically measuring it intraoperatively, and the refraction is going to be done right there, and so that's the biometer readings are going to be less important. But
Mhm.
this is what works for me in my practice. So I think that is really key. And then obviously you have to understand the lens technology. You have to understand what these lenses do and don't do, the good and the bad. There's no perfect solution. And I mean, I'm relatively straightforward. I mean, maybe I'm even conservative on certain things. I don't do a lot of multifocal IOLs on post RK patients, post refractive. There are guys that'll do that, no problem. And if they have to go back and do an IOL exchange or do a piggyback lens or do refractive surgery on top of that, that's fine. And, that works for some people, that's great. I like to have one operation per eye as much as possible and have that turn out really great and the patients are happy. I don't like to go back and do lots of touch-ups and reoperations. Obviously, you need to be able to do those. You need to be able to reposition an IOL occasionally if you need to. You need to be able to do a refractive touch-up, whether it's LASIK or just an LRI on a patient. You may need to do an IOL exchange. You need to have that skill and knowledge to really get the outcomes you want, but it should be a low number. But I think there's a wide range of technology, and each surgeon kind of has to decide what is going to work best for him or her, depending on what their goals and what kind of lens implants and what kind of practice they have.
So once the practice was ready, you needed to attract patients who valued and were willing to invest in premium vision solutions. How did you go about building that clientele base, and what role did education and communication play to make that happen?
I think that the number one way that happened was through building a large referral network. And I have a fairly large optometric referral network and some MDs as well. That happened not immediately. That required a lot of groundwork by the practice and by me. When I came in to Atlanta in 2010, I had been in Charleston, South Carolina for 3 years. So I basically just parachuted into a new place and nobody knew who I was. So I had to go out and ingratiate myself and shake hands and have a lot of face-to-face meetings with a lot of doctors in and around the Atlanta metro area. And after a little while, some started sending, and then more started sending, and more started sending. And once they started getting good results back and getting good feedback, they felt comfortable to send more. And then that just grows. That's it's a sort of a self-fulfilling prophecy. It sort of grows organically, because once that wave of patients, word of mouth comes back to the doctor and the doctor's happy and things went well, then that doctor will tell other doctors and that patient will tell other patients. So that really kind of grew exponentially over time once I got established. And then the online presence became more of an issue, as I said, or more of a support in the last 5 years. And then certain things like, some of the online awards, if you will, or, WebMD award and, Castle Connolly and all that. And patients do look at that, those things help. And so each thing compounds and builds on the next. But I think you have to really get patients to have a terrific experience and have great results. There's an old adage: if you do a great job, the patient might tell one person, but if you do a horrible job, they'll tell 10
everybody.
people. Right. And so, you don't really get a lot of reward for doing an okay job or even a good job. You have to do a great job, and you have to really get the patient to really feel excited about what was done and like you and like your staff and like their experience. Then they'll actually go out and say, wow, I had a great experience. Not just, I had surgery and it was fine. I had a great experience and everything was amazing. Everything was handled really well. And I really enjoyed, the way this was done. And I really like these people and feel comfortable. That really grows the practice a lot.
So when you're talking about all these pieces fitting and working together, and if one thing is off, will patients notice? I mean, do you find that the patients are that attuned and keen to knowing that, like you've done your job, and just one thing didn't go right? Say, someone didn't, follow up within, within, an hour versus, instead it was 2 days and they just kind of forgot about.
Yeah.
Does that impact the end result and their perception?
Yes.
Really?
Yes. It's become.
Wow. You almost have to be perfect.
Yeah. It's become very much that way. And I think the more doctors you speak to, not just ophthalmologists, but I mean, just in medical practice today in 2025, people's patience in general is really low. Their expectations are through the roof, and they expect the wait times to be short. They expect the visit to go quickly. They expect everybody to treat them perfectly. They expect to have the doctor with the most wonderful bedside manner. They expect the doctor to be a genius. They expect everything to be explained quickly and easily. They expect the cost to be affordable, and they expect all of the follow-up to be amazing and the results to be spectacular. And if any one of those things does not fulfill their expectations, you'll hear about it. So, I mean, patients are very comfortable giving feedback. I encourage feedback. We encourage feedback. Obviously, I like positive feedback better, and I get mostly positive feedback.
Yeah.
but sometimes negative feedback, and sometimes it's just, there's nothing you can do about it. I mean, nobody's perfect 100% of the time. I use an analogy a lot to patients. I use a lot of analogies, frankly, and I get made fun of for it a lot. But one of the analogies that I use is, you can go to the fanciest restaurant in town, and if you ask all 100 people that ate there at the end of the night, probably 97 or 98 of them are going to say it was the best meal they ever had. And there's probably going to be one or two that say it was the worst meal they ever had and the biggest waste of money. And they ate in the same dining room with the same staff and the same waiters and the same food and everything. And it's just, you're not going to be perfect all the time. And small mistakes, a phone number got misplaced or somebody, missed a call. These things happen, but you really kind of have to set the bar nowadays at, we're going to try and do everything to the highest level we can throughout each patient visit from start to finish. And that's a really high bar, but I'm telling you, that's the bar that I set. And no, we don't achieve it all the time. But if you just say, we're just going to, go through this day and we're just going to get through, and whatever happens, that's not going to build an A+ type practice. If you want to build an A+ practice, if you want to have Ritz-Carlton type, recognition, you have to provide Ritz-Carlton type service, and you have to set the bar, the service level that high.
Well, I would tell you, you are 4.9 on Google, so you're doing a really good job.
And by the way, there was one review that maybe came in a month ago or fairly recently, which was a 1 star, which got everyone's attention. Why was it 1 star? Why was it 1 star? One of my surgical coordinators left the practice to go back to school. So there was a period of maybe a few days where the handoff to the new person that was training and all that. And there was one person who a phone call, just a voicemail got left, and then the phone got handed off, and it didn't get checked for a day or two or whatever. And then it got lost in the shuffle in a handoff.
What? And you got a 1 because of that. And everything else went,
this person basically was of the opinion of, this person didn't call me back for a couple of days. And so obviously they don't care about me. And what can you do? I mean, people leave their jobs, they change jobs. I've had nurses, I've had technicians say, hey, I want to go back to school. Can you write me a letter? And they'll go back to school, and you got to find somebody else. I mean, no one's in their job for forever. And so these things happen. And that was an example of, you can't control everything all the time, but you have to set the bar for saying, we're going to do absolutely the best job from start to finish at every level on every patient. I know that's a high bar, but honestly, that's the bar that I set.
With so many options in the refractive and cataract space, from laser vision correction to MIGS and advanced IOLs, how do you decide which procedures and technologies to offer under your premium umbrella? Because you can't do them all. I mean, like you said, it can be confusing to a patient. How did you narrow it down to the ones that you can really be excellent and exceptional at, and as well as your team be able to support?
It's a really good question, and I think it comes down to a variety of things. I think number one, your training. If you're somebody that's training nowadays, you're getting exposed to laser and all kinds of different new technologies as a resident. Some of us who are a little bit older, sometimes you got to pick up things, after you come out of training. And once the technology comes online, you have to go out and seek the technology, take courses, go to the academy meeting or Asperis or other meetings, or do a fellowship or whatever. So I think some of it is that. Some of it is just your personal level of interest or motivation or comfort in using certain technologies. Some people are very comfortable working on the cornea. Some people are more comfortable working in the anterior segment. Some people are more comfortable doing strict cataract, straightforward procedures, and others want to do more complex things. And then I think also it has to do with what kind of practice do you want? Are you really looking to do vision correction, or are you looking to just treat cataracts from a medical standpoint? I mean, if you have an older, population that's more of a Medicare population, Medicare, Medicaid, with a lot of pathology, they're probably, demographically, you're probably not going to have a high premium adoption in that in that demographic. If you can build a practice, I'd say my practice skews slightly younger and healthier than an average ophthalmology practice. So that allows me to see younger patients that are in their 40s or 50s or
Oh, wow.
occasionally 30s, that are asking for vision correction options because maybe they are not a LASIK candidate, or maybe they have a job requirement that just makes it difficult for them to wear glasses or contact lenses. And so you want to be able to offer things for younger patients or for healthier patients or for people that don't want to wear glasses. So again, then, you decide, okay, I'm going to look at multifocals. Which multifocals, focal or focals do I want to offer? Which EDOF lenses do I want to work with? And, you have to reach out to the companies, you have to talk to the sales reps, you have to go to meetings, there's, key opinion leaders and things of that nature. There's tons of videos and courses at the AAO that just took place last week where you say, hey, you know what, this guy, I really like this doctor. He or she is an expert in, refractive surgery. I'm going to kind of see what he or she does, and I'm going to kind of follow that pathway. So I think there's a lot of different opportunity to pursue whatever avenue you want. You just kind of have to decide what type of practice, where am I, what kind of patient demographic do I have, and what's my comfort level, what's my surgical skill level, and then you can kind of go from there.
You mentioned that your patient population tends to be younger, like in the age of like the 40 range. That's like that's clear lens exchange territory. Or do you
Well,
offer
I
that as
wouldn't
well?
say the average. Yeah, I mean the average is not 40. What I mean
Oh
to
no, that
say
it
is
skews low. It skews younger though, right?
correct. It's correct. I would say instead of being what I would think of a typical cataract practice as a 65 and up
Hmm, hmm.
practice. I have patients obviously in their 60s, 70s. I mean,
Sure.
I had patients that are 100, but I also have people coming in their late 30s, 40s, 50s, who are not quite cataract age yet, but are aware of whether it's ICLs or clear lens, or whether you call it clear lens extraction or refractive lens exchange or
Right.
prelex, it's pretty much the same. And they've heard it either from word of mouth, they've seen it online, they've talked to their referring doctor, which is usually an optometrist, and maybe it's somebody, and this is just, one example. Maybe you've got somebody who's 40 years old, 47 years old, who's now presbyopic, who's minus 10 or minus 8, and maybe they're not a LASIK candidate. So, and they're thinking, well, I don't really want to wait 20 years to have cataract surgery, and I'm not really an ICL candidate. So maybe let's look at a clear lens. The person's already wearing, let's say, contact lenses for distance, and then they have to wear reading glasses on top of the contacts, or they're wearing bifocals or trifocals, and because of something with their job or something that they like to do, they really can't wear glasses, or maybe they're contact lens intolerant. I mean, there's so many different permutations of people who have come in and just said, what can you do for me? So then it's a matter of obviously looking at their eye health and looking at the picture and saying, well, here are the risks of the procedure at your age versus at a later point. Here's the time frame. If you want to do it now, here's what we can do. You don't have to do it now. You could always wait. And a lot of times after hearing all that, a lot of these younger folks are saying, you know what, I'd just like to go ahead and do it. And so that kind of, again, like it's sort of word of mouth online and just from referrals from doctors that know that I do these kind of things. That's kind of how these things build.
So artificial intelligence, AI, is making its way into every aspect of medicine. How do you think AI is beginning to influence your diagnostic decisions, surgical planning, or even patient engagement?
Well, AI is, I mean, everybody's talking about it right
Yeah.
now. And actually, I was not in Orlando, but I live streamed it, and there's quite a few on-demand lectures about AI and ophthalmology that
Really?
they're actually on my list, on my playlist that I need to go through and kind of see what's changed since last year. I think AI is already involved. I mean, when you call certain call centers, or when chat bots and things like that online, whether you're just looking up information or you're trying to reach someone, after hours, a lot of the time you're going to start off with an AI chatbot. And so, it's following that. So a lot of times you're getting answers to your questions from AI.
Hmm.
In the near future, I suspect that after hours call centers and things like that, or even certain clinical sort of, I have a red eye, what is this? You're going to get AI to come back and say, here's the differential diagnosis. You type in all your different symptoms. And do you have pain? Do you have discharge? This, that, and it's going to tell you it's probably either A or B, and so I think it's going to become more important diagnostically. There are already femtosecond laser platforms. I won't get into specifics, but there is a femtosecond laser platform which literally calls itself robotic cataract surgery.
Seriously?
Because right now, I mean,
it exists and it exists now and it's in the market.
I mean, it does certain things slightly differently than other femtosecond laser, but I mean, one could make the argument that femtosecond laser assisted cataract surgery uses certain robotics or certain technology to automate the procedure. I don't know that I'd call it robotic surgery or AI, but that's sort of already there. And I know for a fact that there are a number of companies that are working on fully automated robotic surgery. I mean, cataract surgery, where literally a patient would go into like some kind of like an MRI machine type thing, and it would sort of, the bot would actually come in, and instead of the surgeon's hands, the actual mechanical arms of the bot would do the procedure. Now, sometimes that's like what's the Da Vinci robot that they use for general surgery, where a surgeon's at a console on the other side of the room using these trocars, and the patient and the bot are over on the other side of the room. So the surgeon is controlling the bot. But then now, I mean, at some point that some of these things will probably be fully automated. Obviously that's a ways off.
Yeah.
But I do think AI is going to be ever increasing in the healthcare field. I know there's certain fields where they're saying, well, AI is here and is coming and is going to be taking a lot of jobs away. I suspect that healthcare definitely will. In the hospital, why send a human being into a room with a patient with TB or, COVID, if you could send a bot in there to, bring a tray of food or take a sputum sample or whatever,
right?
So for safety, certain types of jobs like that, I know it will penetrate into ophthalmology in a more profound way in the coming future. But it's definitely already starting to show its head a little bit.
Mm-hmm. Mm-hmm. So with declining Medicare reimbursements and increasing costs, many ophthalmologists are exploring cash pay opportunities with good reason. Mm-hmm. How has the economic pressure shaped your strategy, and what lessons have you learned along the way?
Yeah, I think the economy now, as it has at various other times, does affect patient decision-making in terms of A, should I have this procedure at all? B, should I do it now or should I do it later? C, what kind of out-of-pocket expenses are going to be if I do a premium, adopt a premium technology? And also, frankly, I mean, am I even insured? I mean, the number of insured people, a lot of people just are losing their Medicaid. There's these subsidies for insurance, which is part of this government shutdown right now, the decision to include insurance subsidies or not. So these pressures and inflation, the cost of living, so these things do have an impact. You obviously, if you have a higher adoption of fee for service or out-of-pocket expense or premium technology in ophthalmology, that is going to offset some of the Medicare cuts and some of the other, financial strain on patients. And also, by the way, running a practice is more expensive than ever. The labor costs have gone up over the last few years. The cost of insuring employees, the cost of benefits for employees, rent, the amount of technology that it costs to run a successful ophthalmology practice, having all of these biometers and lasers and scans and everything. It's incredibly expensive. And so, yeah, there's pressure from both sides, on the expense side and on the reimbursement side. And so you have to be incredibly savvy now. You have to be very efficient. I think the days of doing a low number of cataract surgeries, of primarily traditional standard cataract surgery and being highly profitable, that is probably going to be a thing of the past. Mm-hmm. I think there'll be a fewer number of ophthalmic surgeons doing a higher number of surgeries each to really kind of be profitable. And you want to be efficient, so you have to have, you want to schedule as many cases as you can and be as quick as you can and have the least number of complications as you can on your surgery day. And you want to, see the maximum number of patients in the most efficient way possible in your office setting, and, control overhead costs by, not having a ridiculous amount of technology. You have to pick and choose what works. So
Mhm.
it is very difficult. It is very difficult. We could have a we could have a 3-hour conversation just about practice, how to manage a practice successfully and make ends meet and all that, with all the pressure on ophthalmologists and physicians in general nowadays. But those are just sort of some highlights, I guess, are the main things to look at.
Well, that's a whole nother show,
Yep.
Dr. Brody. So I mean, kind of in that same vein, I mean, it seems like it could be really challenging, somewhat daunting in a lot of aspects financially, both from the patient side and costs and all those things you just went over. On a personal level, what keeps you motivated to continually evolve your practice model rather than simply maintaining the status quo?
I think, well, first of all, I actually really enjoy what I do. I really like ophthalmology. If I could do it all over again, I probably would stay right where I am doing what I do. So I think if you love what you do and you enjoy the people you do it with and the setting you do it with, I think it makes it easy to remain motivated. And I think ophthalmology is a very innovative, forward thinking, forward looking field. There's always new technology. There's always improvements coming along, whether it's better lenses or better technology or better drugs. So, and vision is something that's just so important to people. I mean, it's almost, if you ask patients, what's literally the number one thing other than just being alive, most people say their vision. I mean, it's really at the top of their list. So it's such an important thing that that really keeps me motivated to want to just continue improving my skills, improving patient care, getting better outcomes, expanding my practice, and it keeps it exciting. I'm sure at some point, um, I'll feel like, okay, I've done what I need to do. And maybe at that point, it'll be a little bit older and closer to retirement. But right now, I'm still very motivated and enjoying the technology and the innovation and the excitement of it.
Mhm. So finally, your colleagues listening who may be considering a similar pivot towards premium pay or advanced technology models, what advice would you share about getting started and building something that lasts?
I think do your homework, talk to key opinion leaders or listen to key opinion leaders, learn, watch videos, go to meetings, go to the labs at the meetings, the surgical skills labs. There's some fantastic educators, that even if you're out of practice already and you're not in your residency, if you are in your residency, do a residency, do a fellowship in an area that you're interested in, get the surgical training, get the hands-on training that you need from the appropriate people. And if not, if you're out of practice already, it's never too late. It's never too late to learn new skills. And you have to put yourself out there. You're going to have to get out there and practice. You're going to have to do these surgeries on patients. You're going to have to get comfortable with the technology. And once you feel that something works, then go with it. If something doesn't work, move in a different direction. Sometimes I see patients coming in that had technology that I personally did not have good success with, or maybe didn't have spectacular results with. And I see people doubling, tripling down and saying, well, there's better technology out there. Sometimes you just have to pivot. Not every new technology becomes a great technology. I mean, not every invention becomes a great invention. I mean, so many different, just staying within ophthalmology, lens implants or technologies that, we did RK for a while. And then we realized, hey, maybe cutting the cornea 16 or 20 times is probably not a good idea. And then we did LASIK for a while. Then we kind of moved away from that. Then we did SMILE for a while. Now we're looking at ICLs. And so, new technology comes. You have to be willing to adopt new technology and look at what works and what maybe didn't work. And, you have to kind of follow the results and follow the outcomes. Where the outcomes are good, go there. If the outcomes are not great or it's questionable, time to switch gears and move to something else. There's always something else you can try.
Mhm. Sounds like investing in yourself and having a high sense of awareness and engagement is kind of the key.
It's multifactorial, multi-layered, but every little bit helps. Yes.
Well, that was Dr. Jason Brody from Woolfson Eye Institute sharing his journey of vision, innovation, and leadership, and how reimagining the patient experience can open entirely new pathways for ophthalmic practices. If there's one takeaway from today's discussion, it's that the future of ophthalmology isn't just about adopting new technology. It's about thinking how we deliver value to patients in a world that's changing faster than ever. Huge thanks to Dr. Brody for joining me today and for the team at Woolfson Eye for continuing to set the high bar of excellence in private practice care. Before we jump, Dr. Brody, if any member of our audience wanted to reach out and learn more about what you had to say on today's topic, what's the best way they can reach and contact you?
You can email me at jbrody, JBRODY, at wolfsoneye.com, WOOLFSONEYE.com. Or you could go to the Woolfson Eye website, www.wolfsoneye.com. There's a link on there to my bio and to all the offices where I work, and feel free to make an appointment or reach out that way as well.
Awesome. So, as always, we'd like to thank Riverside FM and Passionate Media for making this show happen, and Meridian Medical for making it all possible. That's a wrap for this episode of the Q-Switch Conversation podcast. Until next time, this is Spence, and I'm out.
Thank you, Spence.
You're listening to The Q-Switch with your host, Spence.